So, Ashley, thank you so much for your participation and presentation on this event, and definitely kicking it over to you to kind of get things started. So thank you so much, Ashley.
Great. Thank you so much, Chris. I'm very excited to be here, and I thank you all for taking the time out to listen to this presentation. It's something really close to my heart, and something I've been professionally focused on for about the last 5 years. So just to talk about some learning objectives today, I want each of you to be able to walk away from this presentation and be able to identify at least one risk adjustment methodology. There are a lot out there. But I'd like for you to be able to identify one. And then also I'd like for you to be able to describe how risk adjustment impacts quality scoring and payment methodologies as the country is shifting more to a value-based approach to care delivery. Also, I'd like for you to be able to verbalize what is CDI's role in risk adjustment. Like Chris said, I started in this capacity more in the ambulatory world, working with the Clinical Integration Network, which transitioned more into the ACO. And learning about value-based care and what that is, that really, everything I researched just opened up to CDI. CDI just kept coming up in my research. And that's where I learned that, it's really important the language that we use and how that gets translated into the codes, and then how that becomes the data that's used to measure and score our hospitals and physicians. So I think it's really important before we get into what is risk adjustment and how does all that work, we have to start with the basics of what is value-based care. Value-based care is a healthcare delivery model in which providers, including hospitals and physicians, are paid based on patient health outcomes. So why are we transitioning this way? Well, that's because our healthcare costs are so out of control and we're not seeing the outcomes that we'd want to see. Value-based care is changing the way hospitals and providers are getting reimbursed. We're seeing a shift away from the traditional fee-for-service, where you order a test and you get paid for that. Now it's showing a focus more on quality instead of the quantity. So heads and beds are going out the door, and we're looking at the quality of care and patient outcomes. So value-based care shifts the focus of healthcare delivery from an episodic and volume-based approach to a value, quality of care, and patient-centered healthcare delivery strategy. That is the theory behind value-based care and what our goal is. So when I was thinking about how do I tie value-based care into real-life scenarios and what does that value actually mean? To me, when I'm looking for value in healthcare, I'm going to look for it in the same way that I would anything else. So if I'm going to go out and buy me a new purse, I want a great value in that purse, which means I want something that's high quality, that's not going to fall apart as soon as my son starts putting in his little plastic dinosaurs and I'm carrying around all my work goodies and all that. I want something that's going to withstand the test of time, and I want to get it at a good cost. And that is what equals value. Quality over cost equals value. So now we're going to talk just a little bit about what are some of the payment methodologies are out there. Now that we know what value-based care is, we're looking for high quality care at a reasonable cost. Let's talk about the way that we get paid. So through CMS, there's traditional Medicare Parts A and B, that's your fee-for-service. Medicare Part C, that's your Medicare Advantage plans. And they really, really, really utilize risk adjustment in that plan, which I hope a lot of y'all are aware of that. There's also some quality-based incentive programs. There's the quality payment program that includes MIPS and APMs, that's alternate payment models, and merit incentive-based payment system. There's also the value-based purchasing, which is more of the inpatient side. That's where they're looking at quality of care over the spend, and they are either penalizing hospitals with payment reductions or giving them some bonuses. Also, there's on the inpatient side, there's the hospital readmission reduction program. Another payment methodology is the DRG system. We're all familiar with that. That is its own payment methodology right there. And then within the private sector, that's where we talk about some of the contracts, along with like CINs and other entities that do that. What I want you to take away from this slide is there's a number of different ways that our physicians and our hospitals get reimbursed. But what's important to know that it really doesn't matter which avenue that we are going down to get paid. Risk adjustment is going to affect every single one of these. And we'll talk a little bit more about how risk adjustment affects these. So we've talked about what is value-based care. And we've talked about some of the payment methodologies that are out there. And we know that value-based care is quality over cost. So how do you measure quality? How do you determine if a provider or hospital is providing high-quality care? Well, there are different types of measures that we can use to do that. There is process measures, and some good examples of process measures are ED throughput. In CDI, you may not be familiar with that measure, but that is looking at how long does it take a patient when they come into the facility to be seen by a physician. Another good example of a process measure is within the ED throughput sets. How often are our patients coming into the ED and leaving without being seen by a provider? What we're doing there is we're measuring the processes within the facility or within that department to make sure that we have all of our ducks in a row. Some outcome measures, and I think these are probably the easiest for me to understand because they're very just straightforward. And a great example of an outcome measure is your surgical complication rate or your readmission rate, your mortality rate. Those are patient outcome centered. So what's confusing, I think, for a lot of people when they're looking at data and trying to understand what they're actually reading is it's hard to understand what you're reading if you don't know where the data comes from. So administrative data is collected via claims, which includes the ICD-10 diagnoses. So administrative data is used in the calculation of several different quality metrics, and a lot of those metrics are publicly reported. So if you've heard of Leapfrog, your CMS star rating, things like that, a lot of that information is claims-based or administrative data, and that is reflective directly of what was put on the claim. So in my head, what I have to picture is we have the documentation. We come in and do our job as CDI and coders, and we translate that documentation into a code. That goes out on a claim that eventually becomes the data that is populating these quality measures. So that's one source of data. Another source is from the patient medical records, and that's usually where your quality department comes in, and they are manually abstracting information out of the records for specific metrics. And usually those staff members are specially trained in whatever registry they're looking for or whatever measure they're abstracting for. Another way to get information on the quality of care and also maybe patient experience is patient surveys. I'm not sure if you guys have heard about HCAPS or anything like that, but that is also part of value-based purchasing and is a very big part on the value-based care spectrum. So we've talked about value-based care, we've talked about payment methodologies, and then how do we measure quality? So this is where we need to start talking about risk adjustment and what is it? So risk adjustment uses ICD-10 diagnosis codes to identify patients with higher severity or complexity from others. It compares health status and wellness among populations. It can help predict cost and the quality of care that's provided, because not every patient is alike. So talking about just that separating out different type of patients from others, that sounds a lot like the DRG system. You know, not everyone that has an MCC is going to have the same outcome as someone who has no MCC or CC. So you're putting them into a different type of DRG grouped by patient type and likeness and severity of that patient. Risk adjustment also allows insurers to predict and allocate the amount of funds or money that they're going to need to care for their patients based on how sick they are and how many comorbid conditions they have. So a low risk or healthier patient will ideally use less money to take care of them than a patient that is a higher risk or sicker. Some examples of the risk adjustment methodologies are the CMS hierarchical condition categories, or HCCs, and that's what I'm going to focus on today. That is probably what, in my opinion, the most cross-cutting risk adjustment methodology, where you're going to hit a whole bunch of measures if you follow the HCC methodology. There's also the HHS HCC methodology, and then like I just mentioned before, DRGs are their own risk adjustment methodology in and of itself. So how do you tie risk adjustment and quality together? Well, when we appropriately and accurately capture ICD diagnosis codes, we allow for complex patients with comorbid conditions and complications to have a smaller impact on some quality measures. So depending on the quality measure and the payment methodology, so depending on what we're looking at, risk adjustment can be captured and applied cumulatively. So either at a 12-month period, 90 days, or just based on the episode or encounter-based risk adjustment. Some examples of where we would use 12 months to risk adjust a patient on the inpatient side are your value-based purchasing mortality measures. Those are risk adjusted from 12 months before the index admission using the HCC methodology. The 90-day period for risk adjustment, that's where you're going to look at your Medicare spend per beneficiary, and that's also part of value-based purchasing. That also uses the HCC methodology to calculate the risk adjustment. Patient safety indicators, or PSIs. I know this is really starting to make its headway in the CDI world. Those are episode-based risk adjusted. There's not a look back period. There's not a cumulative action on risk adjustment for that. So that encounter documentation and coding really, really matters on that encounter. So let's tie the three pieces together, risk adjustment, quality, and payments. So while providers and hospitals, we still use our traditional fee-for-service model for payments, those payments are what is adjusted, reflected by the quality of care that we're provided. So for value-based purchasing, the patients that fall into those measures are traditional Medicare A and B patients. What happens is the DRG payments get adjusted for that facility based on the outcome of the patients in the cohort. So high value providers and hospitals are rewarded with either payment increases or they just don't lose any money, while low value providers and hospitals are penalized with payment reductions. And that payment reduction is going to be related to your DRG payments. Examples of this are here's a good example of the hospital readmission reduction program. Hospitals can see up to a 3% reduction in your MS-DRG payments if expected performance is not met. Okay, so when a lot of these information is published, you're going to get an O to E ratio, an observed over expected performance. Risk adjustment really plays into the expected performance, and that's how risk adjustment will impact your O to E, is under that expected. You're trying to show how sick that patient is so you can know, am I going to expect this patient to pass away, or do I expect this patient to have a complication, or do I expect this patient to come back to the hospital for a readmission? So we've talked about how that all ties together and how our hospitals and providers can see a reduction in their payments. And a lot of those, like I said, HCC is what is cross-cutting against a lot of these measures. So let's talk about HCCs now. HCCs are groupings of clinically similar diagnoses into condition categories in a hierarchical fashion where the highest severity condition category takes precedence over the other conditions in the hierarchy. So I want to share with you guys the diabetes category and how that hierarchy works. So within diabetes, there's HCC 17, 18, and 19. 19 is diabetes without complications. You can see over to the right the codes that fall within that hierarchical condition category. If you have a patient that has a complication, say CKD or another type of chronic complication, you want to make sure to be able to capture that so you can jump up to the next level on the HCC. And you can see here through the coefficient, I don't know if you guys can see my mouse here, the coefficient on that is very, very different, much more higher weighted. So this is showing that your patient is sicker than a patient without complications. You can see here about how many diagnoses can go into these condition categories of themselves. So for 19, you see we only have 6 diagnoses. In 18, there are 400 diagnoses that can be captured to get you that HCC. So HCC diagnoses must be captured at least once per calendar year to risk adjust that patient. If we're talking about a RAF score and in the ambulatory world. For CMS, that clock resets on January 1st every year. So an example of why it's so important to make sure that we're capturing these HCCs timely and then at least annually, but we probably should capture them anytime that they are relevant to a patient's encounter. An example of this is a patient has a below-the-knee amputation. It was captured in the data and in the claim on 12/1/19. The patient's not seen again by provider until 12/1/20, but the BKA code is not captured on that visit. So in the eyes of CMS, that miracle has happened, that patient's leg has grown back, and they are no longer risk adjusted for that HCC. So it's very important each year that we're capturing those chronic conditions that will risk adjust our patients and show how sick they are and why they might need more care than someone who is not as sick as they are. So like I said, ideally, HCCs are captured at either each face-to-face visit or anytime that they are relevant to that patient's encounter. So the coding guidelines, section 4.j states, code all documented conditions that coexist. This is a practice change for our providers and for our coders, but as we shift more into this value-based world, it's really important, in my opinion, that we capture those and really show how sick our patients are. So I've mentioned RAF a couple times, and if you don't know what RAF is, that is the risk adjustment factor. This is how we're actually measuring and able to see how sick our patients are. So it is a score that's assigned to beneficiaries or patients within, say, Medicare or whichever plan that we're working with. And it's a score that's assigned to them based on their disease burden and includes their demographic info. So basically, your risk score is your expected health status, how well or how sick you are. An average Medicare patient has a RAF score of 1.00. So if you have a RAF score below 1.00, that means that you're a healthier patient. You're healthier than the average Medicare patient. If your RAF score is above 1.0, you are a sicker Medicare patient, and you are going to require more resources and more care to take care of your conditions. So the RAF score is calculated using a demographic coefficient, your HCC coefficient, so those little numbers that were outside the disease categories. And then there's also some disease interactions that you can get a little extra coefficient for, because we know that if you have heart failure, diabetes, and CKD, those all interact together. You're probably a little bit sicker than someone who just has diabetes. So the demographic coefficient, there are several ways that can be adjusted. You can either be a community living, so a person who lives within the community. Non-dual means that you are not eligible for Medicare and Medicaid, and that the aged or disabled tells us how you got into Medicare. You either aged in or you were disabled and you were able to get into Medicare. These are all have different coefficients assigned to them. What we are going to use for when we calculate a RAF here in just a second, we are going to use the demographic coefficient for a 75-year-old community-based non-dual age status. So here's a quick case study. So we had a 75-year-old female who is admitted with pneumonia, with a history of CVA, residual left-sided weakness, and dysphagia, hypertension, COPD, and CKD. At admission, her respiratory rate was 33, her SpO2 was 85% on room air, she had accessory muscle usage was noted, and she was treated with 100% non-rebreather and antibiotics. Speech therapy recommended thickened liquids due to aspiration risk upon swallow screen and study. So based on the current documentation on how this is worded, we would end up in DRG 194, simple pneumonia with a CC. So we've got unspecified pneumonia. Our hemiplegias are CC here. We did get an HCC on here for the hemiplegia and COPD. There's the coefficients. CKD, we have that unspecified, so that does not get us an HCC. And dysphagia, unfortunately, is not an HCC either. with our demographic coefficient, we have a patient with a RAF score of 1.285. This tells me that this patient is a little bit sicker than the average Medicare patient. But being a good CDI and having a great CDI program, I know that this patient is probably a lot sicker than that. I mean, she came in with an SpO2 of 85% and she needed 100% non-rebreather. So we're going to say that the CDI has all the appropriate information. They wrote the best compliant queries. They didn't leave the physician in any way, and they asked, I think it was 3 queries. Yes, so we queried for aspiration pneumonia, CKD, we tried to get that stage, and for acute respiratory failure with hypoxia. So the physician, of course, answered exactly the way we were hoping they would, and told us that, yes, this is aspiration pneumonia, which changed our DRG to 177, and respiratory infection with inflammation. And we also got an MCC because the physician said, yes, that patient does have acute respiratory failure with hypoxia. So I want you guys to look at the changes that we were made just by adding those 3 queries. The aspiration pneumonia is actually an HCC, got a pretty large coefficient for that. The acute respiratory failure is also an HCC, got a decent coefficient for that. We also added CKD stage 4 and got another HCC. On total, our HCC or our RAF score doubled on this patient. So no longer is she just a little bit sicker than the average Medicare patient. She is a lot sicker than the average Medicare patient. And this shows me that I'm a little bit more, I'm going to expect her, I wouldn't be surprised if she had a complication or if she were to come back in the hospital in 30 days, because she's pretty darn sick. So that's a really good example of how the specific documentation and clarification of the acute processes in the body can really adjust your RAF score and your risk adjustment. Acute respiratory failure, that's something that you're probably not ever going to pick up on the ambulatory side. You may, and we'll probably see chronic respiratory failure a lot, but acute respiratory failure, that's an important risk adjusting diagnosis, and also risk adjust your DRG for you as well. So what is CDI's role in risk adjustment? Well, we just showed you a great example of what we are excellent at doing, and that's writing compliant queries. Of course, I'm not going to read to you guys or explain the compliant query practice, but here's the name of it and where you can find that information. Clinical validity. How many times have we reviewed a chart and the physician saying this, but it's really like, we don't have the evidence to support that. And we want to make sure that on the back end, we're not going to lose anything on a denial. So our role also is to make sure that the diagnoses that go in the claim are valid, and they are, we're keeping that integrity of the chart, and that we're really showing what's wrong with that patient. Another role in risk adjustment is collaboration, education, and developing relationships. We have to move beyond the queries. There is a lot of work to be done on the inpatient side, and really getting your hospital leadership to buy in to your program is imperative to get those conversations started and to get yourself a seat at the table. There's a lot of quality issues that it's hard to find. How do we improve our quality of care when we're not quite sure we're looking at patients that need improvement? Where are we failing? It's hard to tell where to do improvements when the data is not accurate. Also, doing departmental education. There are some opportunities outside of just physicians to improve documentation and to really get that the patient's chart to show you how sick they really are. A great way is to work with your nursing staff. I can tell you here in Paducah, we have an annual competency fair. Of course, we've had to put that on hold for COVID, but what I did at the last few years of that is I sat at the table, and every inpatient nurse that came through, they came through my table. One thing I talked about one year was clearly documenting the symptoms of your patient and what our role is in clinical denials. So for an example of that is respiratory failure. if we're not capturing the accessory muscle use, the nasal flaring, how low their oxygen levels get when they rip off their non-rebreather, if that stuff isn't documented, we're not supporting our physicians in their medical diagnoses. So that's a really good way to educate your nurses. Like, your documentation really matters, and it's really important in the back. And as a bedside nurse, I had no idea that any of this stuff went on. Wound care is actually another great way to engage your nursing department, or if you have a wound specialist in your facility, work with your wound care nurses and make sure that they understand that their staging is picked up. And also bedside nurses, their staging of the pressure ulcers can be picked up and coded from their documentation. Making sure that everyone is knowledgeable in the staging of pressure ulcers, and helping them understand how that data is collected. There's a PSI related to pressure ulcers, and that's PSI 3. That's a claims-based measure. So what goes on a claim is what's going to populate that. Also, dietary, that's another great way to work with people within your facility. We have worked in Paducah with our registered dietitians. Malnutrition is a huge opportunity for us. Working with ways to get our dietitians to work with our physicians to take it from a nutritional diagnosis to a medical diagnosis so it can be captured as an HCC. There are also plenty of opportunities to do some audits and find out where your problem spots are. So this is an example of value-based purchasing and all the different measures that go within this. And what I wanted to show you guys is about half of the information calculated for the payment and payment reduction is based on administrative claims-based data. So all of the information up here, so your mortality measures and your complication rates, those are all claims-based. Down here, that's 25% of our score. 25% of our score is also Medicare spend per beneficiary. That's where the cost reduction portion comes into the cost over quality, or quality over cost for value. This is risk adjusted using the HCC methodology. So it's very important that we are impacting this to show that our quality is high quality but at a reasonable cost, and we're not overspending on our patients. So I want to share with you guys a study that we did here at Baptist Health. We looked at heart failure, 30-day mortality, the same measure that's used within our value-based purchasing. And we did an administrative claims audit. So the purpose of this project was to identify any trends and opportunities related to documentation, coding, and risk adjustment in relation to the CHF mortality measure specifications included in value-based purchasing. We also wanted to discover any nuances within the measure that may explain or shed light on why we're having difficulties in improving our O to E, observed over expected mortality outcomes. Here is a link, or at least the name, to where you can go and find this information on CMS, qualitynet.org. All the information for these quality measures are public, they are free, and you can get down into the ICD-10 level specifics on what will actually risk adjust a patient and what won't. So if you really want to impress your quality department in your facility, I would recommend that you study these measures and understand what patients fall into the measures and what will exclude a patient from a measure. And we'll talk a little bit later about sometimes some of these are pretty easy to fix. So specifically about heart failure, we're looking at a 30-day all-cause risk standardized mortality following a heart failure hospitalization. The type of this measure is an outcome measure type. Our data sources are inpatient, outpatient, ambulatory, and VA administrative claims. So it is very important that every avenue or area of the healthcare system, inpatient or outpatient, is capturing these diagnoses. So this is going to be for patients that are 65 years or older that have a principal diagnosis of heart failure, and they are Medicare fee-for-service. These are the ICD-10 diagnosis codes that will kick you into the denominator. You'll notice here that there are some of the combo codes that will kick you into the denominator here, and not just strictly heart failure. And of course, the numerator is going to be anyone who expires within 30 days of that admission date, index admission. There are several exclusions to this measure. An easy one to capture that sometimes can get overlooked is this discharge to AMA. So if a patient is discharged against medical advice, the hospital is not held accountable for the outcome of that patient. Another good example is if the patient has been enrolled in hospice or used a hospice service in the 12 months prior to the index admission. We learned through this study that just discharging someone with a consult for hospice is not actually going to exclude a patient. They actually have to be enrolled into the program. These are also some of the codes that if the patient's had an LVAD or heart transplant the 12 months prior, they'll be excluded, and we need to make sure that some of these codes are captured if they're relevant. So what CMS does is they give you, or each facility, they give a hospital-specific report. And on that hospital-specific report, you get all the patient information. You get to know what day they came in, what day they died, and then they also tell you what diagnoses risk adjusted for that patient. So here's just a quick snapshot of what that would look like on the HSR. You've got condition category 91, which is going to hold your valvular heart disease. A 1 means that, yes, you're risk adjusted, and a 0 means no, you were not risk adjusted. And that's basically all the information that you get on the HSR. So what we did on this audit is that on the index admission, we reviewed for compliance within the coding guidelines, clinical validity, and query and documentation opportunities. The coding summaries were compared with the HSR to validate the capture of the condition categories. After we reviewed the index admissions, we went back into the EMR and reviewed any encounter that was within 12 months, but not exceeding 12 months from the index admission that was noted on the HSR. And we looked for opportunities to either pick up, to improve documentation, et cetera. Since condition categories that were reported on the HSR, sometimes they're reported as a group, and you'll see here, like for diabetes, there's a group of these. It was hard sometimes to identify which exact condition category a risk adjustment would have fallen into. So that was one of the barriers that we had. But luckily, since we do have an ACO associated with our system, they had an HCC dashboard that we were able to utilize that helped us identify where some of the patients fell into. So some of the barriers that we faced when doing this audit was, of course, a lack of access to documentation and coding summaries if the patient had an encounter that was outside of our facility. The HCC dashboard lacked all the condition categories that were used in the heart failure risk adjustment model. And also, the HCC methodology for heart failure uses version 22, when there are more recent versions of the HCC methodology out there. So that's just a couple of the barriers that we faced. So when studying the condition categories that risk adjust for heart failure specifically, I noticed that there were several condition categories that risk adjusted for heart failure, but that were not actually considered HCCs. And this is a list of those condition categories that are not included in the HCC methodology, but will risk adjust for this particular disease mortality measure. And you can see here, like CKD, mild or unspecified, you actually get a little bit of risk adjustment for that on this particular measure. What I also found interesting is that we had condition categories that were excluded from risk adjustment if they were only captured during the index admission. And what I found very interesting here was that congestive heart failure is one of these measures, or one of these condition categories. So if you have a patient that is coming in for heart failure, they have never been seen or it's never been documented or coded that that patient has heart failure prior to that index admission, they are not risk adjusted for heart failure. And to me, that was mind-blowing that we had a number of heart failure patients that fell into a cohort, but were not risk adjusted for it. And I can speak to my experience in CDI that a lot of times when I would write a chronic diastolic heart failure query, a response I would get sometimes is, this isn't relevant to this patient's stay, or this doesn't matter right now. Well, my argument back now that I know this is it does matter on every stay, those chronic conditions. Even if we're not treating an acute exacerbation of heart failure, we still need to capture that in case they were to ever come back for a heart failure exacerbation and then they expire. We want to make sure that we get risk adjusted for that as much as we can. I hope that makes sense. So some of the findings that we found while doing this, we had 8 index admissions. So we looked at 100 patients. We had 8 out of 100 that were identified as having a possible alternative principal diagnosis, either pneumonia or, let's say, respiratory failure or something like that. So that was an opportunity as well, and we need to do a little bit more study to find out what the impact is if we chose a different co-equal diagnosis over heart failure, because that could potentially impact some other measures. We did identify that 4 index admissions were included in the measure because of the combo code as the principal diagnosis, and following the coding guidelines, it was applied appropriately. But the admission was actually due more towards the CKD end-stage renal disease area. But since it was a combo code with heart failure, it was included. It was the principal diagnosis and kicked us into the heart failure cohort. We also discovered that several ICD-10 code mappings to a risk adjusting condition category were present on claims, but they were not captured by CMS in the HSR. That really frustrated me, and so it had me go back a little bit further into the measure and try to figure out why are we not capturing the stuff that I know that was picked up and documented and coded. Well, deep down into the measure, there's a little blurb that says, as a part of the data processing prior to measure calculation, records are removed for non-short-term acute care facilities such as psych facilities, rehab facilities, and long-term care hospitals. Additional data cleaning steps include removing claims with stays longer than 1 year, claims with overlapping dates, claims with patients not listed in the Medicare enrollment database, and records with invalid provider IDs. So there's a lot of different reasons why some of our claims could get scrubbed and we could lose some of our HCCs. So it's just very imperative that we are picking up whenever it's appropriate, in case something should get scrubbed off, or in case somebody puts a wrong provider ID in there and we lose those HCCs. So while we were looking in this audit and we were trying to identify how do we rank and identify our opportunities and how do we know where we need to work on, we decided to rank our opportunities, and the rank was determined by the highest number of opportunities found during the abstraction, along with the total condition categories that risk adjust across the care continuum. So we identified 11 categories. We gave consideration to the ease of implementation, current education interventions that we already had in place, any barriers that we had, and then we also thought about the DRG impact in the final ranking when we were choosing what we were going to work on. Using a tool that was previously developed by CDI, we were easily able to identify the condition categories that risk adjust for CMS condition-specific mortality measures, procedure-specific mortality measures, and also HCC risk adjust for RALF calculations for ACO beneficiaries. So the maximum score that you could get with that was a 7, and then we ranked that with, and I'll show you an example of how we did this. So what we did is we had the audit finding number of opportunities, and we had that continuum of care score, which where you have a total of 7. So we had found out of the 100 charts that we audited that there were 22 opportunities for either the approved documentation, send a query, or a miss on coding to pick up that code. So there were 22 opportunities. This is a high level. It cross-cuts against a whole bunch of different measures and will calculate into a RAF score. So this was our number 1 opportunity, was protein calorie malnutrition on this patient population cohort. And then you can see here what the impact of that could be on the inpatient setting for an NCC, CC, and then also have an HCC. And we did this for the top 11 diagnoses that we found. I'm not going to go through all of this because probably running a little short on time. But you can just see our top 11 that we chose to focus on. These are the improvement opportunities that we found through the audit and some things that we decided to do. It was a lot of education, and then we also developed some tip sheets that I'll share one with you here in a couple minutes. So some examples of our interventions that we did related to learning about this measure and just learning about claims-based measures in general is we developed specialty-specific ICD-10 diagnosis preference list within EPIC, which is our EMR. So when a hospitalist comes in and they're taking care of their patient and they type in anemia, they're not going to get the top 40 diagnoses of OB-related anemias because that's not really related to their specialty. So they go to their specialty preference list and they type in anemia, and then they're going to see, acute blood loss anemia, chronic blood loss anemia, things that are a little bit more relevant to them and their patient populations. Trying to make our tool a little bit easier for the provider to use. We collaborated with consulting departments. I mentioned this before. Registered dietitians, they use a malnutrition severity assessment. We have been working on ways to get that transition from a nutritional diagnosis to a medical diagnosis so that can be captured on the claim and be captured as an HCC. Wound care, mentioned that earlier, and then also nursing documentation. Descriptive documentation to support on the back end for any denials that may come up, and also to support any queries that we may write. Pressure ulcer staging, and then GCS scoring. I know that the coding rules have just changed on this, but I still think it's a really easy assessment to do, and it can tell you a lot about the patient. And that's something really easy that if it's applicable to pick up for code, you can pick that up from nursing documentation. So I think that's still a good thing to continue educating our nurses on. So for provider education, we did several presentations. I'm really lucky here in Paducah to have the medical director for hospitalists to actually be the CDI physician advisor. He's really well respected throughout the facility. And so he's been a huge win for the CDI program here and done a lot of help for us. So we utilized him a lot. And then we also developed tip sheets, things that I just put on the walls for the physicians in their dictation areas. I made a quick tip sheet on, these are the most common diagnoses that you write. Here's how you can do them a little bit more specific. And this is what the impact is, either NCC, CC, or an HCC. And just a lot of repeated education. So here's a tip sheet that we made for our ambulatory coders as they were starting to start their work in the HCC world. And this was for clinical indicators for depression. And this one can also be used for our providers. That was a lot of what we heard when it comes to the specificity of depression is they did not feel comfortable specifying some of that because they're not mental health professionals. So we had, worked with a mental health professional and came up with these diagnoses and some things to look at for the coder's sake. And then this can also be used for physicians too, or nurse practitioners. So we've done a lot of work in Paducah and then through the Baptist Health System on HCC capture. And we're still learning, of course, the impact that has on quality. And in my new role, I hope to align that a little bit more. Here's some sources for you guys if you want to research and look at these specific measures and the specifications for them. If you're nerdy like me and you want to dig down into it, everything you could ever want is there. It just takes some time to dig through it. Here is my contact information. If anyone has any questions, I am happy to answer. Thank you so much for your time.